Hi, I just want to introduce, myself, I suppose. I'm Ashley Aitken, Senior Programme Manager for the Oxford AHSN, involved with real-world evaluation. Sorry if I'm looking over to the side, I've got my screen here and you're all here, so I feel like I'm actually talking to somebody. So as part of the webinar, I'll take you through what real-world evaluations are in a very generic way. I've tried to make it as technology agnostic as possible so that the advice is very generic. So if you do have any specific questions later on, please feel free to ask or pop them into the chat and we'll come back to them at the end. Obviously this session is being recorded, so if you have any issues or anything like that, please let us know and we'll try and chop you out if there's any questions or anything like that. Just a quick introduction to what the Oxford AHSN is. The AHSNs are the innovation and improvement arm of the NHS, and we occupy quite a unique position because we're technically NHS, but we kind of sit just outside. So we deal with industry, academia, and the NHS all at the same time, and we try and match the high value innovations with identified population needs, trying to take into account health inequalities and the views of patients where possible. And we have a track record of improving patient outcomes, experience and safety. There are some case studies on our website and on the National Network webpage for you to go and have a look at. And we try and help save the NHS some money, support the economy through the growth of purchasing, and empower healthcare staff. The Oxford AHSN's clinical priorities are in cardiovascular disease, maternity, neonatal space, mental health and respiratory disease. We do work with other projects in other clinical areas, but these are our key focuses because this is mostly what our ICS is interested in and it's where our local strengths are. Just a quick one really to show our team and expertise. I'm not going to read it all out for you because there's quite a lot on there. They will be sent around hopefully towards the end of the week, so you can just have a quick read through for yourself. But we do have healthcare professionals in our team, so if you need some professional advice, we can help you with that. These are just the integrated care systems that the Oxford HSN are involved with and we work closely with. We as a region cover the Bob ICS and we work most closely with them, but we do have links into Frimley and BLMK with Eastern AHSN. Ooh, got people popping up all over the place. And this is really just a quick overview of the industry and research establishments that we have in our region. As you can see, that there's quite a variance in the type of industries that we've got around here, and they are usually quite open to collaboration. So if you need to collaborate, we can maybe make some links for them with you. And we have worked with quite a few of them ourselves. So we're part of a network of 15 HSNs covering England. We were originally established in 2013 and we are commissioned by the NHS England and the Office for Life Sciences. We work on local projects and we work together on outcomes-led national programs as well, such as the MTFM projects. And you can find your local HSN on the hsnnetwork.com if you want to go and have a look. So getting into what is a real world evaluation, they're usually conducted after all the, they are conducted after all the regulatory approvals have been obtained. You can't do one before that. Anything that comes before regulatory approvals is classed really as a clinical trial. And they involve placing the technology into the care pathway in what we'd call standard practice. So as if the evaluator had purchased it outright and were just starting to use it. They're not as tightly controlled as clinical trials. And the main point of it is to try and prove value to the system, whether that's in financial terms, efficiency in workforce terms, as well as to the patient. They differ quite a lot from clinical trials, though the methods used can be quite similar. And it's actually quite difficult to try and properly explain the difference between the two. So a clinical trial is very academically robust, and they're usually very tightly controlled as to the patients that are going into it. They're usually very expensive, and they involve some form of randomization or blinding to reduce the risk of data biases when you come to analysis later on. As mentioned, the patient population is very tightly defined, whereas a real world evaluation is usually broader and a lot more inclusive, a bit more pragmatic, and it reflects better how it would be used in real terms. Ethics are usually, well, always required for a clinical trial, whereas for a real world evaluation, they're usually not. So you do often have to think about patient consenting if some sort of form of patient data sharing is going on. For example, we've got a project ongoing at the minute where we're having to share patient addresses with a company who are sending out kits. So we're consenting the patient at the point where we're telling them about the evaluation. So we walk them through what we're actually going to be doing with them, so what the kit's going to do, etc., and then consent them to share their details with the company so the company can then ship the equipment out. If the patient says no, then they go down the usual standard pathway. You can have a look at that later on because there is quite a lot on there. So the HSN's role in real world evaluations is mainly to provide guidance on how best to conduct one. Every project is different. I'm probably going to make them sound quite easy through this, but they are all very, very different. And I would encourage you really to engage with your local HSN as soon as you possibly can when you're going through the process. We can broker connections for you to clinicians who may be interested in working with you if you are struggling to get that sort of thing. And we might be able to broker access to baseline data, which we're going to discuss in the third webinar, so I won't go into too much detail. We can also partner with you on grant funding applications. One of the main benefits really of working with an HSN on the real world evaluations, especially if you're going to allow them to do the project management for you, is that it usually gives you a more credible and an independent evaluation of your technology. So when you then go to take it to business case, you can actually present something that's independent and it's not just seen as marketing material from you guys. We can also offer data collection, report writing, that sort of thing, that sort of support. So get in touch if you want any support with that sort of thing. As already mentioned, this is going to be very generic advice. I've tried to keep it as technology agnostic as possible, though I'm going to try and weave in some examples from various different technologies as we're going along. Different technology types and disease areas do require very different approaches, as do different settings for where you can put technology. And as I've already said, if you need any support or guidance, please reach out to your local HSN. They'll be more than happy to support you. Okay, to start with, I think the first thing that should always be done with the real world evaluation really is to determine if there is an unmet need that your innovation addresses and to clearly articulate it. And then that's usually the difficult bit. You need to clearly articulate the issue that you're addressing to help get reluctant stakeholders on board so they can see what you're trying to do, where you're trying to go and what problem of theirs you're trying to solve. The only thing I would caution against when you're articulating that need is to be very careful of sort of the blame game. It's quite easy for people to feel threatened when you're articulating an unmet need. So for point of care testing, for example, taking testing out of the lab and moving it down closer to the patient, it's quite common for somebody in the chain to actually feel like they're not providing a good enough service when that's not actually the case. It's more often that demand's increased and you just need to get patients through quicker. So a 4-hour turnaround time, for example, which would have been fine 2-3 years ago when we weren't seeing as many patients, is now an issue because there's just that many people sat waiting. You just need to get through them a lot quicker, and point of care testing is usually a lot quicker for things like that. So just be careful how that need is articulated. And you will need to map out the clinical pathway that you're interested in putting your technology into. A good place to start is usually NICE guidance. They've usually got some quite nice pathways on there. Some of them are quite complex, so you might need to sort of chop bits out and just make it a bit more simple. And then once you've got that, you can then run it past a clinician who will tell you if that is how it works in their trust, or they can help you map it out if it's something that NICE doesn't have to start with. And then take that pathway and put your technology into it and see if you can change that pathway to make it more efficient. Sometimes a plug and play option is actually enough. You can just take the standard pathway and pop your technology into that path wherever it needs to be. But more often than not, you do need some sort of pathway transformation in there. And you need to think very carefully about how that pathway change will influence downstream. So for example, we did a project a number of years ago around point of care testing for flu in ED, and it did what we wanted it to do, but the unintended downstream consequence of all the isolation rooms being full a lot quicker than we expected. I was not particularly popular at RBH after that for quite a long time. So you've got to think about how your pathway change is potentially pushing a problem just further downstream, and how you can potentially prevent that, or what sort of planning needs to be put in place to minimize the impact of that. And then you also need to think about what data is potentially available for your baseline. So what you can compare your new pathway against, especially in terms of monetary value. And it's quite often things like audit data, clinical data, sort of hospital level data that's held by informatics. So you need to speak with your clinicians and your HSNs just to see what is actually available for you. Something that quite often isn't thought about during an evaluation is how it's actually going to be funded. So you've usually got two options. You can either self-fund, which means you quite often have to provide the required kit and funds for health economics, potential project management, clinical backfill, things like that. So that would need to be costed very carefully, because these things can get reasonably expensive quite quickly, even though it's still cheaper than a clinical trial. Or you can look at grant funding. You may have to wait a while for the relevant grant to come up, and you will need to have your project team, so your clinicians, project manager, methodologists, health economists, etc., all ready for that application. So you will need to do some groundwork before you make the application. Most of the HSNs do actually provide some type of grant application support, but it varies from region to region. So you need to contact your local HSN or the one that you're planning on working with to see what kind of support they can give you. And then the next best thing is to think about clinical engagement. So where possible, I'd always try and re-engage with the clinicians that you've done your original studies with, see if they're interested in doing a real world evaluation with you, just take the work they've already done with you another step. If it's not possible for them, maybe they could introduce you to other clinicians who'd be interested in working with you instead. And that's always helpful, getting endorsement from somebody who's clinical. If neither of those options are possible, again, try and engage with your HSN. They might be able to broker relationships with clinicians in their local area, or they can signpost you to another HSN who has an interest in your clinical area, who can then do the same sort of thing. And if you get a lot of negative responses, don't always take that as a lack of interest. At the minute, we're getting a lot of no thank yous to requests for real world evaluations. And it's not that they're not interested, it's just capacity is an issue at the minute. So keep trying, you will get there eventually. And another thing I would mention about clinical engagement is it's quite possible to tempt clinicians into working with you with the promise of getting them academic papers, because they can quite often get academic papers out of this sort of work. But if they're going down that route, please encourage them not to use the term research when we're talking about these projects, because they're not research. If we start referring to these projects as research, it means we have to go through ethics, we have to go through a ton of other things. And I've had a couple of projects that have almost been derailed by someone on the clinical side referring to it as research because they're getting an academic paper out of it. Someone's overheard it, and I've had to be kicked back to the beginning to then go through all the process of trying to explain to people why it's not research. And it's usually having to explain to medical directors and technology assessment groups and things like that this isn't research. We're trying to do a real world evaluation. We're just getting a couple of nice academic papers out of it. So just be very, very careful about the terminology that you're using with this. And there's a wider engagement piece to be done beyond the clinicians. And it can be quite complex. And it's usually a case of talking to one person, then being pushed on to the next and the next and the next. So this does take a little while, and you do need to put time for this into your project plan. But people you need to think about speaking to is IT, possible integration. That can take a while. And quite often integration for a short-term real-world evaluation is rejected. So you need to think about practical workarounds for things like that. So for example, the flu testing that I've already mentioned, the point of care test we were using should have been integrated into the lab systems and into the patient care records. Because we're only doing a really short evaluation, and the integration probably would have taken about the same amount of time as the evaluation took, IT told us that they weren't going to do it. So we had to look at getting an old school paper logbook next to the analyzer to log all of our results in. And then someone came and manually put them into the lab systems, into the patient records, and into a log for us to use for health economics later on. You will also need to involve information governance, and this does take a while. So you need to look at things like data protection, impact assessments, data sharing agreements, things like that, mainly just to show that you are looking after patient data sensitively and that you're not sharing it more than it needs to be shared, and you're not taking more data than you need to take. Like I said, that they're probably one of the first groups that I would engage with after you've got your clinical engagement, because that can take quite a long time. And there can be quite a lot of backwards and forwards if they're not happy with it. There's technology assessment groups. So if you've got something that is truly novel, most trusts tend to have a technology assessment group of some description with some varying names. They will want to see what the technology is, what it does, and the impact that it's going to have. And they'll probably want a presentation at the beginning and a presentation at the end just to see how the project's gone. And their recommendations will help with procurement and finance as well further down the line. You'll also need the input of divisional directors and medical directors for sign-off of various bits of tech. I would also get procurement involved right at the beginning of these projects. And they're not going to need active engagement until the end, but if they know it's coming down the pipeline, they usually tell you what sort of data they want to see as you're going along, which is always helpful. There's nothing worse than getting to the end of one of these and procurement going, oh, I need to see this. It's like, wish you told me that at the beginning, because I'd have got it for you. So it's always good to get them on board at the beginning. You also need to engage with patients, especially if they're going to be the ones using the technology up front. And the best way usually of engaging with patients is either through workshops with the clinicians or through charities, things like that. So that can be a bit of a difficult one, and that can sometimes require ethics. So you just need to be careful with the project. Just check as you're going along for that sort of thing. And if we're looking at things that will feed into the laboratory system, you need to get them involved, point of care, things like that. This isn't an exhaustive list, so I would have a look at the real world evaluation guide that's available on the network website. And then to start with the actual planning, usually the first step that I would always encourage people to do is engage with a health economist or a methodologist of some description, mainly just to determine how many patients you need to get for some sort of meaningful health economics or analysis at the end of your project, depending on what your desired output is. This is really important if your real world evaluation is going to be used for NICE submission, because they usually want to see a certain level of data above and beyond what would be required for a standard business case. So it's always good to get that sort of advice early and just sort of see where you need to be pitching it at, so you don't have to repeat again just to hit the required number of patients. You also need to determine your patient selection criteria. So what patients and indications are you going to be including? Are you going to be excluding? This can take a little bit of backwards and forwards with clinicians, but I would definitely be led by them, because really what you want to be doing is allowing them to use it in a way that they would in normal practice to get the best value out of the back end of this. Yeah, so definitely be led by them. And then start writing your evaluation protocols, which I tend to approach more like step-by-step guides as to what to do. So you could almost use it as a training package to a certain extent. Include your patient selection criteria in that as well. So if you ever need to take it for sign off, you've got everything there. Data collection forms, if they're going to be required next to the analyzer or by the technology, things like that. And patient information leaflets if needed. They need to be very carefully checked to make sure that they're accessible, they're written in plain English. And there's usually somebody within the trust who can do that for you. But if push comes to shove, you can always run them past family members, things like that, just to make sure they understand it, which is always helpful. And you also need to think about training requirements for clinicians and patients, and you need to get that booked in as soon as you possibly can, because that takes longer than expected. You also need to engage with your key stakeholders that we've already listed and complete any other paperwork that's required, like your data sharing agreements, technology paperwork just for the sign off of any tech that's required, presentations for the technology assessment groups, things like that. And then once all that's together, you then need to go and get any required sign-offs. So things like your medical director, divisional director, things like that. It really varies by trust as to who needs to sign these things off and by clinical setting. So you need to check that early, and you need to leave enough time in your timelines to make sure that's all done, especially if you're kicking it off over the summer when everybody's away on holiday. It does take longer than you think it does. Not the challenges that we quite often come up against. The main one, and this is usually a self-inflicted one if I'm honest, is a very unclear articulation of the unmet need that you're addressing. If you're very unclear about what you're trying to do and what problem you're trying to solve, it's very hard to get clinical engagement and very hard to get the more corporate engagement from the NHS. So you need to clearly state what you're going to be giving them in exchange for their time. It's quite common to come up against a lack of baseline data or comparable data to compare against, especially if you're looking at totally new models of care, or you're looking at a completely new little bit of kit. And it's quite often, if you're looking at something that is preventative, so you're going to prevent things from happening, it's also quite hard to get that baseline data to compare back to. So you can say, I've prevented X number of whatever. That can be quite difficult to get. There is limited time and resource clinically So you need to think about making your real world evaluation as light touch as possible, make it as easy on everybody involved as we possibly can, or look at backfill funding to take some of the burden off that. There's also quite a lot of expectation around what a real world evaluation should show, especially when it's something that we think will be cash releasing or cost saving. And it turns out that that's not actually the narrative that we want to be weaving. So for example, we did a project with PLGF, which is preeclampsia blood pressure testing, where we originally presented it as being cost saving, but because of the way the budget flowed through the trust, we got a bit of pushback on that business case. So we then had to twist the narrative to show it as cost neutral before it would get approved. So we just sometimes needs a little bit of flexibility in thinking about how you present things. You think it needs to be presented one way, whereas actually the trust need it presenting another way, and just roll with it. And not many stakeholders actually understand what an evaluation is for, and the difference between an evaluation and research or a clinical trial. And that needs to be very clearly articulated, I think, at the beginning, again, coming back to the research question. And some of them do actually see it as a judgment on clinical practice. So again, going back to the point of care example, the labs sometimes see it as an indictment on their turnaround times and things like that, when actually that's not the case. We're not saying that anybody's providing poor service or anything like that. We're just saying the situation's changed to the point where we need to put some change in. And that can be quite a delicate conversation to have sometimes. So it's definitely something to approach with caution. Another one is patient drop-off during evaluation periods. We see this quite a lot with apps, where we're asking patients to put a lot of data into apps and that the patients aren't getting anything back from it. So unless there's a real bit of patient education around why we need them to do what they're doing, you do tend to see quite a high drop-off. And that is something that needs to be thought about at the beginning of a project. And there is quite often conflict over what stakeholders want to achieve as part of an evaluation. So the innovator will want to get economic data out of it, for example, whereas clinicians maybe would want to get an academic paper out of it. You can get both out of these projects. It just takes a little bit of flexibility in thinking. So don't let that derail you. So next we're on to implementation. The main thing that we tend to come up against from an implementation point of view is staff training. Do we need to train everybody, or can we train some super users and cascade it down? And how do you keep track of who's had training and who hasn't on the equipment? And can you lock out those who haven't had training from using the equipment or the technology? So that needs to be thought about really carefully at the beginning. And you need to make sure that staff are aware of any QC or calibration requirements for your technology if it's required, and make sure that there's plenty of QC material available for that, especially if we're looking at point of care testing that is attached to a lab. As part of the implementation, you also need to have regular check-ins with your clinicians just to make sure there are no small issues or niggles that need addressing as you're going along. They're usually logistical, and that they usually have quite simple workarounds, but just in the middle of something you're working, it seems a big deal, and quite often the clinicians will stop using something just because it's too much stress. So if you can take a lot of that from them by having regular check-ins, making sure everything's still going as smooth as it should be, you're more likely to have a successful evaluation. Having said that, though, you've also got to allow the clinicians to get on with using the technology in practice, but try and make sure that everybody's following the agreed protocol as far as possible. So we've tried putting some technology in at a GP surgery, which involved quite a bit of pathway change around it. And because we weren't keeping in regular contact with the clinicians because they were just really busy, as GPs are, they sort of drifted away from the originally agreed pathway change back into their old practice. And while they agreed that the technology was really helpful, we lost all cost savings as a result of moving away from that newly agreed pathway. So you've just got to try and make sure that everybody stays on the agreed track. And as part of that, data collection, this is another one that needs to be considered very carefully. Try and make it as easy as possible for a clinician. If you're giving them massive data collection sheets per patient, they just haven't got the time to do it. So you want to look at other sources of data if possible, such as what's being held by informatics, standard audit data, stuff that they're collecting anyway as part of their standard routine, without adding additional on top. There are times when you do have to ask them to collect additional data. Just it needs to be as light touch as possible to keep everybody in track and keep everybody on board, and be very clear about what is required and why it's required. So what it's actually going to be used for, again, because it helps with that engagement and just keeps people doing it. And try and construct really clear, simple data collection forms if required. Like I said, it's not always required. You can get the data from elsewhere, but if it is, try and make it really simple. And also ensure that your data sharing agreement paperwork covers everything that you're asking for, and it covers all the data movement. So if it's coming from the trust to, say, an external health economist, that needs to be covered, and everybody needs to sign that off. And try and take the bare minimum amount of patient data that you can for your analysis, because you're more likely to get data sharing agreement approvals that way. The various types of health economics will be discussed in the next webinar, so I'm not going to go too much into that, and it's not really my area of expertise. But the health economics will require your baseline data, if there is some available, and all of the evaluation data that has been collected. So like I say, if you do need to export that data to an external health economist, you need to consider that when you're putting your data sharing agreements together, and have your economists lined up at the beginning of the project. The health economics will be used to inform your business case, and it goes towards justifying the system spending money on your technology. So it usually gives proof of cost savings or cost release, as well as showing patient benefits like reduced length of stay, reduced antibiotic use, etc., which also have costs attached to them. And they need to be considered very carefully from the beginning of the evaluation, because they inform the metrics that you will need to be collecting as you're going along. Implementation packs aren't always required, but they can be very helpful. And especially for products that potentially need further rollout across the trust. So you've evaluated them in a very tight niche that can then potentially go out further. Implementation packs can be really helpful. So they look at all the paperwork that's required for implementation. So any sign-off paperwork you've needed, things like that. Protocol for its use, the barriers faced as part of implementation and the actions that you took to overcome them. Practical considerations like the logistics, like moving kit around the hospital, things like that, staff training, list of key stakeholders to be engaged for implementation, and a brief overview of the health economics. It generally tends to give procurement and finance a little bit of extra information that isn't usually included in the business case templates that are provided. So if you can do one, I would strongly recommend that you do one, but they're generally not an essential. We also have a example implementation pack, which is on the resources slide a bit later on, that we've put together for PLGF. It is a very involved implementation pack. Most implementation packs aren't anywhere near that sort of size, but it just gives you a good overview of what sort of thing to think about including in them. And then once everything's done and dusted, you've got your health economics, you can then start looking at putting a business case together if you can show that this is beneficial to the system. Templates do vary from setting to setting. So I would always approach the trust that you're working with to ask them if they've got a template that you can use. It generally tends to go down better with finance and procurement if you use their template, because they know what they're looking at and they know what the information that they need is. Business cases usually ask for the following. So things impact on budgets. So is it cost saving? Is it cost neutral? That sort of thing. Impact on the system. So does it introduce efficiencies? What sort of impact on the workforce are we looking at? You know, are we saving time? What sort of training, etc., is required? And the patient impact. So things like improved outcomes, reduced length of stay, etc., things like that. Business cases don't usually ask for QALYs because most finance and procurement people don't really deal with QALYs. That's very much for NICE. So again, when you come to do your health economics, you need to look at whether or not you need to be collecting the metrics required for a QALY. If you're just looking at a business case, health economics, you don't need to worry about it. If you're looking at going for a NICE submission as well, then you need to take advice from a health economist on what sort of thing you should be looking at. Some of the HSNs can assist in drafting business cases, especially if they've been involved in the evaluation. But from what I can remember, some of the other HSNs will also help with business case writing support, even if they haven't been. So just go and approach your local HSN for any support that you need. So a quick recap. Real world evaluations are to be conducted post regulatory approvals, not before. They are definitely not research, though research can come out the back of them, and do not usually require ethical approvals. The technology is to be evaluated in as close to a normal use case as possible. You need to carefully consider your pathway at the beginning and engage all the key stakeholders across that pathway as early as you can. And you really need to consider the logistics of implementation. It's quite often not as easy as you think it's going to be. And conversely, there's some that look like they're going to be really awkward to get in from a logistical point of view, and they're actually quite easy, which is always nice. But your main aim for the real world evaluation is to prove proof of value. You should have already proven that it does what you say it does as part of your clinical trial. So you shouldn't need to reprove that. And AHSNs are here to support you through the process. So please take advantage of the support that is on offer. Like I say, it varies from HSN to HSN, but we are always more than welcome more than happy to support you. As mentioned, there's some additional resources. So there's the network guide to real world evaluations, the PLGF implementation pack. We've got some case studies of some of the real world evaluations that we've worked on over the years. And there's a link to our next webinar, which is the Introduction to Health Economics. I will PDF these and send them around with a recording of this for hopefully the end of the week. So you should be able to go and check all that out. And that's enough of me talking. So has anybody got any questions?
There's 2 questions in the chat, if you can see it.
Oh, yeah. Okay. In terms of grant funding, do you involve in early stage R&D projects or only in later stages, clinical trials / evaluations? So we can't get involved in what is pure research. EY, if you want to chip in, feel free. You can. Have you taken everybody off mute, Rochelle?
He should be able to unmute himself.
Yeah, okay, so if you want to unmute and chip in, feel free. So we can't get involved in what we would call pure research. That's for the NIHR to get involved in. But once you started moving into the translational space, so you're starting to look at how it can be commercialized, for want of a better term, though I know some of the products that we work with aren't always commercialized. Once you look at working with it in patients, we can get involved in the early stage proof of concept sort of research for that sort of thing. So we can definitely get involved in that. You have to go back to the NIHR usually for the clinical trials. We're not allowed to get involved in that, though we can give advice from a health economics point of view. And then you will come back to the HSN network for evaluation. Does that answer the question?
Yes, if I may sort of clarify that a little bit, what that really means. AHSN, for example, when we develop a new product, obviously in the beginning we have requirement gathering, analysis, prioritization, etc., etc. That's really in terms of developing the technology, developing the product.
Yeah,
the early stage R&D. That's what we mean. But
okay,
that's what
we can definitely help with that. So when I see early stage R&D projects, I tend to think my brain automatically goes to academia. So we can't get involved in that purely academic research, but if you're starting to look at making it into a proper product, definitely, we can definitely get involved in that. And the earlier you can get us involved, the better, because we can help you develop something that is NHS ready, because it's quite easy to go from what is an amazing idea into something that can't really be used in practice.
Right. So to answer that question, it's basically you can involve in early stage R&D. So Innovate UK funded projects. At the early stage, for example, requirement gathering, etc. Definition.
Like the proof of concept sort of level.
Yes. Oh, perfect.
Definitely.
That's AHSN, right? Okay.
Yes. So if you want help with that, reach out.
How do we get in touch with?
Oop, hang on.
Yeah.
There we go.
Yes.
So you can either contact me direct or your local HSN directly, and just walk us through the project. We'll be more than happy to help.
Perfect. Thank you.
Yeah. If you're going for grant funding or something like that, though, please try and get us involved as early as possible, because it can be a bit stressful trying to get these things in 2 days before deadline.
Understood. Thank you.
Yeah.
Thanks.
Okay, and the second one, in terms of location, is real world evaluation always in an NHS setting? Not always, but more often we are mainly involved with the NHS. So it's what sort of situation were you thinking about, Ravi?
Hi, Ashley.
Hi.
See, when we talk about real world, right? There's not always a clinician in your WhatsApp contact list, right? So there's no, and that's what we understand the real world setting. So when you mentioned about nice clinical pathways and clinicians as stakeholders, it gives just the impression that real world data is also always collected in an NHS PCN primary care setting. So that was the question. Is can, for example, I have a mobile app, a regulated mobile app for anxiety. And the data we collect in a real world, could it be like normal consumers access?
I mean, so as long as the technology is going to be usually paid for by the NHS in some way, shape, or form, it can, the actual evaluation can be pretty much anywhere. It's more just us proving value to the NHS system. So say if you've got I don't know, say a CBT app, for example, that you maybe want a PCN or an ICS to pay for, but the actual usage is going to be out in the real world with the patient, that's generally not a problem at all. Is that the sort of situation you were thinking about?
Yes, of course. I mean, the question was, again, we're looking at it from an NHS lens as a single payer in the UK. And the assumption is that the benefits or or the results from the real world evaluation would be used to sell it into an NHS setting, which is one way of doing this, obviously. But if you look at the private market or the insurance companies or employers, whatever, it may not necessarily be in an NHS setting, and you don't have to prove cost savings to the system because it's not the system that is paying for it. That was because now we are confused. Now you're mixing market access, and evaluation, and real world evaluation. So that was my question, basically.
Yes, because we're commissioned by NHS England, we really have to focus on the NHS. If you want to collect data as part of, say, a real world evaluation that you're doing with one of the HSNs to address the other options, then that's fine, but it's not really something that we can advise on because our focus has to be for the NHS.
Thank you.
Yeah, sorry about that. Any other questions? No? Because if anything else does pop up or does come to mind, my contact details are there, so please feel free to reach out. I'm more than happy to answer any questions anybody's got.